Good evening, everybody. A warm welcome to today's ICS webinar on obstructive airway disease series. We have a very, very special, extremely interesting, and extremely enlightening topic today, which is so useful in our day-to-day management. So we're going to be talking about COPD management in 2024. And for today, we have the most fantastic faculty who's going to run us through and teach us everything that we need to know about COPD. So to begin with, I would like to invite today's moderator, Dr. Prashant Chhajed, who requires no introduction whatsoever. He is the pride of Mumbai, he's the pride of Maharashtra, he's the pride of India, and he's one of my bestest friends who I just love to spend time with. In addition to that, he's a great, great achiever. He probably has the highest number of publications I know anybody of having. And all of these are not only Indian, but also international journals. He's a fantastic interventional pulmonologist. Every time we are stuck, we send our patients to Prashant. A brilliant clinician, an excellent academician, and a great human being. So over to you, Prashant. Please take over.
Great. Thanks a lot, Amita, for this very, very kind and generous introduction. Yes, Amita is, we don't have to tell anything about Amita. Everything, all the super things are very well known. She's a fantastic person, very active, very dynamic, arranging, a fantastic clinician friend, and also, a super organizer of all the academic feast that is that's happening. So really, Amita, thanks for this opportunity to moderate this. I really would like to thank the Indian Chest Society for this opportunity. I want to thank Dr. Sandeep Salvi, Dr. Amita, Dr. Rajadhar, as well as Lupin for helping to get this program happen. Next slide, please. Yeah. So now, for today's topic is basically related to COPD. It's very important. We are going to discuss about COPD management in 2024 and the state. Sorry. I have to stop this. Sorry. Can't stop this. Yeah, sorry about that. So we are going to discuss about COPD management in 2024, state of the art. We are going to have a lecture by Dr. S Yuvarajan, and who is sorry, my thing is gone again because I tried to mute that thing. Just hang on. Where is my stuff gone? Sorry about this. All this has happened because the WhatsApp call went off. Yeah, where is the... Just a second. I just need to expand my... Not sure why I'm not able to do it. Sorry about this. The WhatsApp call which came on the computer made all the problems. Hang on. Second, I've just lost my screen. Yes, so I think I've got a part of the screen back. So Dr. Yuvarajan is the professor and head of Department of Respiratory Medicine, SMV MCH Hospital in Puducherry. His professional position is professor head and also the Secretary Association of Pulmonologists at Puducherry. He's got multiple awards and achievements as far as pulmonary medicine is concerned. He is also published a lot, 78 articles. He's got 2 books. He's got 4 chapters. So Dr. Yuvarajan is one of the dynamic clinicians as well as academicians, And today he is going to tell us, he's going to speak on the COPD management, all that you want to know. After this, what we'll do is we have an expert panel, as Amita said. We've got a very good set of fantastic clinicians who will help us to discuss about COPD management in the year 2024. So over to you, Dr. Yuvarajan.
Yes, sir. So thanks for the introduction, sir. Thank you, Amita madam, and the whole team of ICS for inviting me for this wonderful webinar to discuss on the most important clinical, topic, that is COPD management. So can I share the screen? So I could not.
Yes, sir. Let me show you, sir. Please proceed, sir.
Yeah. And proceed.
Yeah, finally,
Not see that. Can you see my screen, sir?
Yes, sir.
Okay.
Could you please open your PowerPoint presentation now?
This is okay? Can you see my screen?
We can see the screen, but the presentation is not being seen. We are
Okay.
Yeah,
seeing
you will
like
need to open. Yeah,
files,
just
etc.
open the presentation. Yeah.
So already it is open, sir. 1 second, I'll close and.
No. So you need to go to PowerPoint. Please select PowerPoint and take slideshow. Please select PowerPoint on your screen.
Okay, sir.
Should I guide, sir?
It's selected, sir. It's selected, but I don't know why it is not coming. 1 second.
Yeah, there you go. So just you just need to put a slideshow.
Full screen. Yeah, full screen if you can do, please.
Yeah. Can you see the screen now? Can you see the screen now?
Yes, we can see the screen.
Once.
Can it be made bigger, the screen? Is it possible?
No, only this much only, no? Like.
Okay, fine. No problem. Fine.
So what I'm going to discuss for almost like 20 to 30 minutes, 20 to 25 minutes is on COPD management, all that we want to know. So I'm going to cover, shortly what are the changes that they were made, that was made in gold guidelines regarding the definition, regarding the new concepts that were introduced in COPD guidelines, like the PRISM and all these things, and touching on the management part, and then pharmacology and non-pharmacological management and other issues. So you see that there is a remarkable change that was introduced in the new definition of COPD when compared to the old definition. I feel that this definition is complete, and as we are seeing the new definition, that they have included all the aspects in the definition. COPD is a heterogeneous lung condition. As we all know that the presentation differs among the individuals in terms of symptoms, in terms of progression of the disease, in terms of response to the treatment. That's why this terminology is very apt for this new definition. And it is characterized by chronic respiratory symptoms, which includes, as you see in other chronic respiratory disease, you also get dyspnea, cough with sputum production due to abnormalities in smaller ways, predominantly in the form of bronchitis or bronchiolitis, associated with alveolar destruction in the form of emphysema. That leads to the persistent, often progressive airflow obstruction. See, they have just included the presentation part, and then the clinical symptoms and the pathology, and then what clinical, manifestation that leads to the problems in COPD. Everything is included in the new definition. Whereas the old definition, it was more of a, the definition with more of positive, feel as a preventable and treatable disease. As you all know, the COPD is not a disease which can be completely cured, or, you can better opt a complete treatment. You can give a symptomatic management and opt the patient to live a better life with all your modalities. So these are the new, things that were introduced in, Gold 2024. It's a pre-COPD and PRISM. So pre-COPD is the thing is that, like, some individuals will have respiratory symptoms. When you see the, their imaging, they have a structural lung lesion in the form of emphysema. They also have a physiological abnormalities. When you do a spirometry, they have a low normal FE1. There is evidence of gas trapping, hyperinflation, reduced diffusion capacity. Everything will be there. But like as per the criteria that was laid down for the definition of COPD, for the diagnosis of COPD, you should have a FEM to FVC ratio less than 0.7. That is a post-bronchodilator value should be less than 0.7. Whereas these group of patients, they have all the symptoms, they have a radiological findings, they have a clinical parameters, radiological parameters, and then physiological abnormalities in the form of low FEV1. But they can't fit into that diagnosed COPD as their FEV1 to FVC well above the 0.7 range. So these subjects were labeled as pre-COPD. So in this, actually, they have introduced a term called PRISM. This we call it as PRISM, that is preserved ratio, the preserved FEM to FVC ratio with impaired spirometric values. So usually the parameters like they have a low FEV1 has been proposed to identify those individuals who have a normal ratio but abnormal spirometry. The patients with the pre-COPD and PRISM are at risk of developing airflow obstruction over the time, but not all of them do so. So we don't know that which group of patients progress, but there are certain indicators are there which group of patients are progress, but we can't take these patients as lightly because these patients, even though they have a normal ratio at the time of presentation, they have a poor FEV1 and the FEV1 regression will progress over the time. And these patients also have contributed to the morbidity and mortality for the chunk of COPD cases. So that's the thing that, so which group of patients we need to monitor, how long we have to monitor, and all these things need to be answered in further studies. So these are the definitions that are revised. You see that as we see pre-diabetes, pre-hypertension, pre-eclampsia, and pre-cancer, there's a term that pre-COPD that you need to understand. These patients may not fit with the diagnostic criteria of less than FEM to FVC ratio less than 0.7, but they have all the clinical symptoms that is pertaining to COPD. They have a radiological findings pertaining to hyperinflation, emphysema, gas trapping, everything. But the ratio will be normal for these patients. So those patients who have a classical symptoms of chronic cough, sputum production, with or without sputum production, or the patients with dyspnea. So suspected patient with exposure to risk factors. So we have to do a spirometry for the diagnosis. Any patient with a post-bronchodilator FEM to FVC less than 0.7, we can easily label them as COPD. If the patients have spirometry, if FEM to FVC above 0.7, but FEV1 is less than 80%, then we can label this patient as those patients with preserved ratio with impaired spirometric findings. If the FEV1 is above normal, above 80%, that they are considered as a normal, spirometry. So what is the importance of PRISM? You can see this, interesting, paper like association between the preserved ratio at the impaired spirometry and the clinical outcomes in US adults. So if you see the all-cause mortality, those patients who have a PRISM, and they contribute significantly to the morbidity and mortality. All-cause mortality is also higher. It is comparable to those patients who got an obstructive spirometry at the initial presentation. And they also have a CH-related mortality and respiratory-related mortality also higher when compared to those patients who present with a classical FEM to FVC ratio less than 0.70. And when you see the, this meta-analysis, which included almost like 8 studies, having a subjects of around 750,000 population. In this also, you can see that there is a link with the PRISM patients having high risk of morbidity and mortality. And you see the, the prevalence of COPD. Actually, if you see the prevalence of COPD, most of the times, like it is largely underdiagnosed in all the countries. So in this group, in this study, interesting study, if you see that they have screened the patient with low-dose CT and spirometry. So you see that 1/3 of population have undiagnosed COPD. But as per the, pooled analysis, almost like 11.3% of, is the prevalence ratio of COPD worldwide. So, but it differs upon the areas and largely it is underreported that we need to understand. And next most important thing is that, our age-old teaching is COPD is mainly due to cigarette smoking. But this is, proven beyond doubt that there are a lot of non-smoking COPD we are seeing in our day-to-day practice. That's why they have come up with a new ETO-type classification for COPD. They labeled us as the different forms like COPD G, D, and environmental COPD, exposure to environmental agents like smoking and other biomass fuel exposure. And those patients secondary to infections, particularly in a country like India, post-TB sequelae related, airway, obstructive airway disease, forms a major chunk which needs a lot of research, which needs a lot of additional data to go about the management, what we have to do for this patient. And of course, COPD and asthma, which is categorized as COPD A, and COPD U, which is unknown factor, like which leads to obstructive airway disease. So we have already discussed this. The global burden of COPD as per BOLD is around 11.8 for person for males and 8.5% for females. And substantial prevalence of COPD is varies between 3 to 11% among non-smokers. Based on the BOLD, the global prevalence is around 10.3%. So as we have discussed that it is not only the cigarette smoking is important risk factor. We need to sit with the patient, take a proper history. Other exposures also you need to ask: biomass fuel exposure, occupational hazards, and other things like childhood infections, especially tuberculosis, post-TB. All these things has to be registered in your case sheets. And nowadays we are seeing, non-smoking COPD. This can be very well explained with these trajectories of different lung function. As you all know that our lung functions peaks it gradually increases and peaks around the age of 25, and FEV1 declines from the age of 30. And there's a pronounced decline in certain patients, especially those patients who got a risk factor of exposure to smoke and other forms of biomass fuel, or those patients who have a low baseline FEV1. Particularly those patients who have perinatal insults. That's why I always tell to my postgraduates and other junior consultants that you need to give importance to the early life events. Like you need to ask the history, like low birth weight, any meconic aspiration, prolonged stay in the hospital, frequent hospitalization visit, any history of admissions. All these things has to be registered in your case record. One more major addition in the new guidelines is that a new section of hyperinflation has been added. Why that importance has to be given for hyperinflation? That resting hyperinflation, which is based on this paper, you can see that, which is measured as the ratio of inspiratory capacity to total lung capacity, is an independent predictor of respiratory and all-cause mortality in COPD patients. That's why hyperinflation, we need to target these group of patients with hyperinflation also to counteract their symptoms and also to reduce their morbidity and mortality. So in this you can see that by deflating the lungs, reducing the hyperinflation, the pulmonologist will help the cardiologist, because hyperinflations, what will happen, like it will reduce the venous return, it increases the pulmonary vascular resistance, it also causes the compression of the intrathoracic cardiovascular parts. So all these things actually, degrade the patient, and it will worsen the situation of clinical presentation. So that's why we need to, put a check on this hyperinflation part also. And this part is this concept is very interesting. That is dysynapsis. Dysynapsis is nothing but the anthropological parameter, the ratio of mean airway lumen diameter to the total lung volume that is quantified in the CT. This is not the new concept. This is there for more than 50 years. But now with the advent of CT, we can clearly indicate that the lung volume is larger, and whereas the airway volume is not up to the mark to the lung volume. So that's why the diameter is also very small. So these group of patients actually having high risk of developing COPD. That is well proven beyond the fact, but we don't know, like we need additional data and studies with multiple centers to exactly go about this concept of dysynapsis with COPD. As we know that after the diagnosis of COPD with the help of spirometry, that is FEV1 FVC ratio less than 0.70, we have to decide, we have to assess the severity of airflow obstruction to decide on the prognosis, and we have to decide on the therapeutic decisions. What are the drugs we can use, and what are the non-pharmacological strategies we can use, and all these things. This is a interesting table that we are following for years. Like once you confirm the diagnosis of COPD with spirometry with FEM to FVC less than 0.70, after assessing the airflow obstruction, we can grade the airflow obstruction based on the spirometry. That is gold 1, 2, 3, 4. Gold 1 is FEV1 more than 80%. Gold 2 is 50 to 79. 3 is around 30 to 49%, and gold 4 less than 30%. Once you assess the airflow obstruction, you need to give importance to symptoms and the risk of exacerbation, because in previous guidelines, like some 5 years back and all, so we were giving importance only to the spirometric parameters. But COPD can't be managed with only seeing the spirometric parameters, but we need to give importance to the symptoms. We need to give importance to the treatable traits, and we need to put a check on exacerbation. That will prevent the future morbidity and mortality in this group of patients. That's why we need to ask about the symptomatology, and you need to grade the breathlessness. So the grading we can do with MMRC, and there are other CAT scores and the composite scores are there. The Gold recommends to use the composite scores because that gives a more clear picture how much difficulty they are getting in their day-to-day activities when compared to MMRC. But MMRC is worldwide known, and even the undergraduate level also, people used to take a history with MMRC for grading the breathlessness. That's why you can use MMRC also. So with 3 factors like symptomatology assessment with dyspnea scoring with MMRC, and then with the exacerbation history, we can just classify the groups into A, B, and E. Previously, A, B, C, D, E was there. So CD was removed, and now E has been included in the recent guidelines. So in Group A, these patients have a MMRC with a range of 0 to 1, and CAT score is well below 10. And this group of patients also have 0 or 1 moderate exacerbation that doesn't lead to a hospitalization. Whereas Group B, they have MMRC more than 2 or equal to 2, and CAT score more than or equal to 10. And they also have 0 to 1 moderate exacerbation without hospitalization. Group B is the patient who are at high risk of developing all morbidity, mortality, and most symptomatic among all of your patients. They have more than 2 moderate exacerbation or more than 1 leading to hospitalization. So this is the usual grouping that you do after diagnosis of COPD. So in this group of patients, what we can offer to them? So, as already I clearly mentioned that we can't completely cure the disease in COPD. We can better opt as symptomatic management, and we can reduce the hyperinflation. We can put a check on the treatable traits and prevent exacerbation. That will lead to the, good quality of life and, symptom-free period for these patients. In Group A, these patients are less symptomatic. So we can prefer a single bronchodilator. Either it may be a LABA or LAMA. There is no, comparative study that LAMA is better than LABA, or LABA is better than LAMA, but we can choose based on your preference and all. So a single bronchodilator is enough for Group A patients. Whereas in Group B patients, so you can use 2 bronchodilators. You can choose either use LABA along with LAMA. In Group E, once again, you use dual bronchodilators with LABA and LAMA. And definitely those patients who are not responding, having a frequent exacerbation, ICS can be used, inhaled corticosteroids can be used. And these, the subset of patients who are eosinophilic phenotype. So basically the patient's blood eosinophils more than or equal to 300, or the patients having frequent exacerbations, but eosinophils in the range of 100 to 300 also, we can give the option of inhaled corticosteroids along with the dual bronchodilators. So as I already mentioned, this is the grouping of patients and the options that we are having for these patients, like a single, dual, and then with inhaled corticosteroids. So follow-up treatment, so if the response to initial treatment is appropriate, you just maintain the same treatment for this patient. If not, definitely you need to check the compliance for the compliance and also adherence to the inhaler technique, and possibly interfering comorbidities you need to see, because COPD is not a pure lung disease, it's a systemic disease. We need to check on the comorbidities. If the dyspnea is out of proportion, you need to see for other contributory factors for dyspnea. That is very, very important. As a clinician, you should not miss that contributory comorbidities. And consider the predominant treatable trait to target dyspnea, either the patient having dyspnea or exacerbation, which trait the patient you want to give importance. Use exacerbation pathway if both exacerbation and dyspnea need to be targeted. So suppose if the patient have a prominent dyspnea, the same thing, like you can either choose a LABA or LAMA initially, a single. Later you can add both the drugs, and consider if the patient not happy with that, you can switch the inhaler device or molecules depend upon the patient preference and easiness. Implement or escalate non-pharmacological treatments, because COPD is more than a pharmacotherapy. You need to teach the patient how to cope up with the breathlessness. There are other non-pharmacological strategies, like you can use a pulmonary rehabilitation, which has been proven well beyond the fact that if you include these patients on pulmonary rehabilitation program, they can very well cope up with the breathlessness. They can do a normal day-to-day activities without much difficulty. And if the patient still have a dyspnea, obviously we need to rule out other causes which contributes to dyspnea, like the patient may have underlying CAD with cardiac contributory factors for dyspnea. The patient may have an embolism, or the patient may have a pneumothorax, or other things like pneumonia. All these things has to be ruled out. Suppose the patient isn't having frequent exacerbation, you can opt for the same single agent first, and then you can add 2 agents, 2 bronchodilators, and add a ICS, provided the patient belongs to the eosinophilic phenotype. The eosinophils are more than 300. If the patient is having eosinophils more than 100, also you can just choose LABA-LAMA ICS, but provided definitely ICS actually having a slight increased risk of pneumonia, the group of patients. So we need to put a check for ICS whenever option is there for you. You need to cut down the ICS for this group of patients, and those patients who have blood eosinophils less than 100. So we have once again 2 options. We have roflumilast, which have been marketed a few years back. Now we are not seeing much of the companies with roflumilast. And those patients, which patients we choose roflumilast is that those patients who have FEV1 less than 50%, and those patients have a chronic bronchitis phenotype. So this group of patients we can choose roflumilast. And obviously azithromycin long-term macrolide also is preferentially used in patients with the former smokers. provided if their blood eosinophils are less than 100. So these are the non-pharmacological management options. Like one is like recommended. We need to, for group A patients, definitely we need to encourage the physical activity, because of dyspnea, the patient restricts his activity. That actually is a vicious cycle. We should not ask the patient to restrict the activity. We should encourage the patient to cope up with the blood pressures and to improve the activity. That will improve their muscle mass. And then you need to take care of the nutritional part, because these patients actually, they'll go for a malnutrition and they go for a muscle atrophy, and then they'll go for a sarcopenias and all these things. Not only because of nutrition, a disease per se itself can cause all these things. So they have a quadriceps muscle, also will go for sarcopenia. So all these things actually you need to address while managing the patient's COPD. The most important thing is to prevent the further exposure to risk factors. If the patient is an active smoker, you need to give importance to smoking cessation strategies. You can counsel the patient, and you can include all the pharmacological treatments. One of the most important strategy all of us use for chronic respiratory disease is that to prevent the patient to come to hospital once again due to any cause. The most common cause we see in our clinical practice is infections and pneumonias and all these things. So that's why vaccination plays a major role in preventing the patient to come to hospital and prevent the patient to prevent exacerbation. So we can recommend for flu vaccines, COVID-19 vaccine, pneumococcal vaccines, pertussis and shingles vaccines, and included recently shingles and RSV vaccination has been included in the gold recommendation and all various international recommendations for patients with chronic respiratory disease. And most important trials, 2-3 trials actually we need to understand the role of triple drug therapy in patients with COPD. So I have been telling you that the dual bronchodilator along with inhaled steroid has to be chosen for only for those patients with eosinophilic phenotype. But it is proven in these trials like IMPACT and ETHOS trial that when you add these 3 agents like inhaled corticosteroids along with 2 bronchodilators, it is very well shown from the studies that it reduces the moderate exacerbation. It also reduces severe exacerbations, and also it reduces the rate of hospitalization. And even the death hazards also, if you compare, those patients who got all these 3 agents, the death hazards ratio and the hazard ratio is also very well less when compared to other groups, like those who are using ICS-LABA and those who are using LABA-LAMA combination. And when you are using inhalers, like whether you can use a single inhaler use or multiple inhaler use, so you can see that obviously those who are using single inhalers, they are comfortable in using that, and their compliance will also be very good based on various studies, and you can see in these studies also. So those patients who are using single inhaler, they are just continuing these inhalers for a long duration. That improves the compliance of the patient. And you can see that single inhaler therapy has a greater improvement in efficacy endpoints when compared to multiple inhaler therapy. So you need to choose a SIT, that is single inhaler triple therapy, when compared to multiple triple therapy for COPD. So when you choose a non-pharmacological strategies, like I have already told you, we need to put a check on dyspnea and exacerbations. The self-management protocols we can teach the patient. We need to teach them how to cope up with the breathlessness, energy conservation techniques, and stress management strategies. You need to counsel the patient, and most of the patients will have anxiety, depression. We need to check on, put a check on this part also, and include all these patients for PR program. And maintenance exercise program also should be done for post-PR, has to be advocated for all these patients. And the patients with exacerbations, we need to teach them how to avoid their aggravating factors, how to monitor and manage the worsening of symptoms, and you need to tell them whom to contact in case of exacerbation. And other strategies, like we depend mostly on oxygen for certain group of patients. Long-term oxygen therapy is proven beyond the fact, like it increases survival in the patients with the chronic resting arterial hypoxemia. In patients with stable COPD and moderate resting and excess-induced oxygen desaturation, prescription of long-term oxygen therapy does not lengthen the time to death or first hospitalization or lung function or 6-minute walk test. But only thing is that it increases survival, but it doesn't increase your length of time to death or hospitalization risk and all these things. Resting oxygen at sea level does not exclude the development of severe hypoxemia when traveling by air. So all these concepts have been mentioned in your recent guidelines. And regarding the ventilatory support, like that we are going to discuss in panel discussion also, the NIV plays a major role. So you should avoid intubation in patients with COPD. Those patients who got a borderline respiratory failure, not a life-threatening respiratory failure, definitely NIV plays a major role in preventing the intubation, preventing the collapse of this patient. So those patients who had pronounced hypercapnia, or those patients who have a acidosis in the range of 7.2 to 7.25 to 7.35, we can opt for NIV, preferably a BiPAP. And other treatment strategies like we have lot of IP procedures have been mentioned in the recent COPD guidelines. So those patients who have a chronic bronchitis with chronic mucus production, we have a nitrogen cryosp and rheoplasty. All this under recommendations and trials. And those patients who have frequent exacerbations, so you can put a check on acute and chronic bronchitis. They may have a bulla, they have emphysema, they have a tracheobronchomalacia. So targeted lung denervation has been proven in some centers, but still under trial. Those patients have a dyspnea. Definitely, you need to check on their lung volumes, bulla, and tracheobronchomalacia has to be checked. So different options are there. We can go for a giant bullectomy. We can put valves, coils, and sealants, lung volume reduction surgery, and finally, if nothing works, we can proceed for lung transplantation. So those patients, the frequent exacerbation, obviously have a reduced quality of life, and they have accelerated disease progression also. So that's why we need to give importance to exacerbation, and prevention exacerbation is very, very important. Once a patient comes to hospital with increased dyspnea, what will happen? That will also that will cause dynamic hyperinflation. That will increase the lung volume. Once again, that will increases the hyperinflation. It also causes mechanical discharge of the diaphragm, and everything actually is a vicious cycle, which further worsens the dyspnea and further worsens the ventilation perfusion mismatch. So this is actually contributory to all the pathology. So that's why we need to put a check on exacerbation. So in the recent guidelines, they have slightly changed the definition of exacerbation. So exacerbation is defined as characterized by increase in the dyspnea or increase in the cough and sputum production that worsens in less than 14 days, which can be accompanied by tachypnea and tachycardia, often associated with a local and systemic inflammation that is caused by either infection or air pollution or other insult to the airways in the form of dust, fumes, or other insults or chemical dust. So how do you manage this group of patients? The management of severe but not life-threatening exacerbation. So in this group of patients, you need to assess the severity of symptoms. You need to ask for ABG, and you need to ask for a chest X-ray to look for other contributory factors or evidence of pneumonia and all these things. Administer supplemental oxygen, obtain a serial ABG, and if you need a ABG, like frequent ABG, so you can also use venous blood gas. Also, we are doing study on this comparison of feasibility of venous blood gas with arterial blood gas for the ease of the patients. And bronchiolitis, obviously increase the dose and frequency of short-acting bronchiolitis for this group of patients with exacerbation. Combine short-acting beta-agonists and anticholinergics, and consider use of long-acting bronchiolitis when the patient once becomes stable, and use of spacers and air nebulizers when appropriate. All these strategies has to be followed as a part of pharmacotherapy in this group of patients. Obviously, systemic corticosteroids, even though the evidence is not so robust, definitely corticosteroids plays a role, at least for a short-term basis, in this group of patients with exacerbations. And sometimes if you consider infection, definitely antibiotics, oral or injectable antibiotic, when the signs of bacterial infections are present. Consider non-invasive mechanical ventilation also, that we are going to discuss in the subsequent slides. And all the times, you need to monitor the fluid balance, because these patients are more prone for dehydration. Consider subcutaneous heparin and low molecular heparin for thromboembolism prophylaxis, because these patients are having multiple risk factors for thromboembolism, and we are not offered to lose these patients with pulmonary embolism. Identify and treat associated conditions like cardiac failure, arrhythmia, and pulmonary embolism and all. And this is the interesting data. So like comorbidities, like we think of other comorbidities like cardiovascular comorbidities, hypertension, metabolic syndromes, osteoporosis. All these things actually we need to use multiple consultants into our chamber and then manage accordingly. But based on this COPD gene study, you see that interstitial lung abnormalities are very common. When we do a screening CT for all these patients, interstitial abnormalities are very common. The suspected ILD is present in half of those patients with ILA in COPD gene study, and is associated with the excess decrements, increased symptoms, supplemental oxygen use, and severe exacerbation. So those patients who got a worsening of symptoms, and those patients who have a increase in the duration of supplemental oxygen use, always better to do a CT also. CT plays a major role because these patients have a hidden abnormality in the CT in the form of interstitial abnormalities. And this is a major addition. Like dupilumab has been recommended or licensed, given approval for use in COPD, especially those patients with the eosinophilic phenotype. FDA has given not for inclusion in for dupilumab for the patient who have a frequent exacerbation and those who have a higher eosinophil count. So in patients with COPD who had a type 2 inflammation indicated by elevated eosinophil count, add on to the treatment with the dupilumab, result in the lower analyzed rate of moderate to severe exacerbation when compared to placebo. So other therapies like those patients who have alpha-1 antitrypsin deficiency for young COPD, we can use intravenous augmentation therapy, but it is very common in particular population, but it's not very common in Indian population. Antitussives, there is no conclusive evidence of antitussives. You should not use it. Vasodilators, obviously, we have pulmonary hypertension is a common comorbidity in patients with COPD. We are actually, stimulate to use all this vasodilators and all, but vasodilators actually worsen the ventilation pressure mismatch. We should not use. Actually, the studies also show that it is not improving the outcomes. At the same time, it may worsen the oxygenation. And opioids like low dose, long acting oral and parenteral opioids may be considered for treating dyspnea and patients with COPD. And all the drugs for pulmonary hypertension, which is approved for primary hypertension, should not be used in patients with COPD pulmonary hypertension. So these are the strategies we have discussed. Lung volume reduction surgery, bulloctomy, and transplantation also can be offered for selected patients. These are the contributory factors like we need to rule out when the patient with exacerbation, whether we are dealing with pneumonia or whether dealing with embolism, with all the investigation, like we need to do the D-dimer, CT angiogram if the clinical scores are high, and do a NT-proBNP echocardiogram. All these things we need to see when the patient presents with exacerbation. And when you see the patient with exacerbation, we need to assess the symptoms. We need to assess the severity based on different parameters, and you need to establish the etiology, why the patient comes with exacerbation, either because of infection or the environmental trigger. So based on that, we can classify this patient into 3 groups: mild, moderate, severe. So based on the dyspnea, based on the respiratory rate and heart rate, if the patient have VAS less than 5, less than 24, and heart rate more than less than 95, the categorized into mild. And severe patients, those patients have a respiratory more than 24, heart rate more than 95, and then CRP more than 10, and then they have PCO2 more than 45 and pH less than 7.35. So already I discussed this. We need to give importance to the bronchodilator. Systemic corticosteroids plays a major role in this group of patients, but should not be given more than 5 days. And indication of NIV is basically those patients who present the respiratory failure, having a PCO2 more than 45, pH less than 7.35, increased workout breathing with all the axillary muscle usage, and persistent hypoxemia after using oxygen also. So those patients who are actually moribund, who have a poor GCS, not tolerating their NIV or NIV failure, if you are monitoring the patient after 1 to 4 hours, worsening of ABG with worsening of pH, definitely we need to shift the patient for invasive ventilation. And the follow-up, we have strategies for follow-up 1 to 4 weeks and 12 to 6 weeks, 16 weeks. All these things we'll discuss in the panel discussion. So ultimately, these are the interventions we can give to reduce the frequency of exacerbation. So these are the bronchodilators we can use, and the anti-inflammatory like roflumilast prevents exacerbation. We need to give vaccination and long-term macrolides in selected patients, and mucoregulators. Obviously, presence of mucus plugging is an important risk factor that increases dyspnea and increases the risk of exacerbation, risk of infection. So we can use mucoregulators in selected patients. Other strategy like smoke cessation, rehabilitation, all these things we can give. And most important thing is that role of CT actually can be done, because we need to see that these patients are having high risk of developing lung cancer. To pick up their nodules, we need to do a low dose CT screening also for this group of patients. And with this, I'm ending there's no session, like we can discuss all these things in the panel discussion. Thank you, sir.
Great, Dr. Yuvarajan. That was a fantastic talk, a complete overview of all the, a very good overview of all the current updates, which you've really covered very comprehensively. So thanks a lot for that. So I think you've set the stage very well as far as the panel discussion is concerned now, and I'm sure the lecture was so smooth, but you might have some clinical points that the audience might want to discuss, or some questions which you might want to, which you might have. So please put them in the chat box, and we will take it on. Now, to discuss this COPD further, we are joined by a very esteemed experts of panelists, as Dr. Amita had mentioned even earlier. So first, I would like to invite and introduce a dear friend and colleague, Dr. Neeraj Gupta, who's a senior professor in respiratory medicine He's been the former medical superintendent at the JLN Medical College, Ajmer. He's the West Zone chairman for the Indian Chest Society, and he's the secretary for the state chapter of Rajasthan Indian Chest Society. Now, I would also like to invite Dr. Angira Dasgupta. Yeah, and Dr. Angira Dasgupta is a MD DNB in pulmonary medicine. She's done her MRCP from UK. She's got a PhD in biological sciences. She's done a clinical research fellowship at the McMaster University in Canada. She's got her FCCP. She's the additional chief health director, BR Singh Hospital and the Center for Education and Research. She's received numerous awards, including the MR Award in 2017, the GM Award twice, the National Seva Ratna Award from the Ministry of Railways, and she has been invited at many international and national conferences, and her areas of interest within pulmonary medicine are severe airway disease and airway inflammation. So great, Dr. Angira, to have you on board to share your expertise and experience with us as well as our audience.
Thank you.
Next, next I would like to invite introduce Dr. Bindu, who's a pulmonologist, associate professor in pulmonary medicine at the Government Medical College in Thrissur. She's worked at the Health Services of Kerala since 2000 for 9 years. She's actively involved with the TB control program. She joined the Medical Education Services in 2009. She's been the COVID ICU Nodal Officer at GMC Alappuzha, and her areas of interest are COPD, pulmonary rehab, and TB. And COPD is our topic for today. So welcome and thank you very much for joining us, Dr. Bindu. Next, I would now like to invite a dear friend and colleague from Hyderabad, Dr. Vijay Kumar Chennamchetty, who's a senior consultant interventional pulmonologist, and he's also got interest in sleep disorders, thoracoscopy, end-stage lung disease, ILDs, ARDS, and he's also qualified in critical care, pediatric sleep medicine, as well as he's got a fellowship in sleep medicine. So really, we've got a really very well experienced panel and experts who are going to help us to navigate through this session. So now let's move forward in as far as the session is concerned. And for this, I would now like to just a moment. Yeah, I would like to now initiate the panel discussion. Just want to make sure that everybody's logged in and I'm audible to all of you.
Yes.
Neeraj, I haven't said hi to you. Neeraj, hi, how are you? Wow, what a super background you've got, Neeraj. Yeah, really, I like it. That's really fantastic. So, Neeraj, let me start with with yourself. I mean, of course, Dr. Yuvarajan covered, gave a comprehensive overview on COPD. But would you like, for the sake of, expanding and simplifying for the audience, what is COPD as per the current goal guidelines, and what are the diagnostic criteria for COPD based on PFT?
Yeah, COPD for us pulmonologists, it's a very common disease, very common term, and we come across a lot of cases in our day-to-day practice. COPD basically stands for chronic obstructive pulmonary disease. As the name suggests, there is presence of breathlessness, which is chronic, long-standing, slowly progressive, along with cough, along with production of sputum off and on. And ideally, we classify COPD into chronic bronchitis and asthma. Conventionally, chronic bronchitis is defined as cough, sputum production, and breathlessness for at least 3 months in a year for 2 consecutive years. Similarly, emphysema we can define, especially pathologically, by the presence of abnormal permanent dilatation of acini with destruction of the air wall. But the diagnosis of COPD usually is clinical for all of us, when a patient who presents with the presence of risk factors like smoking, exposure to environmental pollution, some genetic factors, etc. Patient presents with chronic breathlessness. There is hyperinflation of lungs on chest X-ray. There is tubular heart, chronic breathlessness, chronic cough, often on sputum production. Then these all characteristics, they define the presence of COPD in that particular patient.
So I think it's very, it's very clear that what has been given in the update is also it's a very important focus as far as the clinical focus, as far as the clinical evaluation of COPD is concerned. There have been a lot of etiologies which have been now defined. And of course, now as far as the PFTs are concerned, we've got both aspects. You've got the classical spirometry, which shows, which can show that yes, there is airway airflow limitation, and the diagnosis of COPD also based on the PFT criteria. But now we've also got PRISM, which was very well described by Dr. Yuvarajan. Would like to really move, take it a little bit further. What will be the findings on iOS as far as COPD is concerned? And I would like to ask Dr. Angira for that. If you could please comment on that.
Okay, so thank you for the question.
And there is also in the chat box also, somebody's asked about using iOS, whether we can treat COPD based on iOS. So if you could cover that as well briefly.
So that's a bit longish question. So we've seen how traditionally we can diagnose COPD with the help of a spirometry, which is a forced effort that the patient has to give in order to get an FEV1 by FVC ratio of less than 0.7. And we need to look at the irreversibility of with the bronchodilator test, 200 ml and 12%, the numbers that we all know by. Now, the problem with doing a forced expiratory technique in spirometry is that patients who have severe disease may sometimes end up having a collapsed airways, and that's the trichomalacia. And then we do not get the numbers that we were looking for. So that's one problem. But the good news about this is that if you do a forced technique in these patients, we will fail. But the good news is that we have the oscillometer now in our hands, the iOS. This does not use the forced expiration technique. What it does is it uses a tidal volume, so that any patient who has got a severe disease might also use an iOS, and the doctor will be able to diagnose COPD in there. Now, when I say COPD, what I mean is that the airway resistance that is diagnosed in the oscillometer will be there. So when we do an iOS, there are two things that we usually look at, that is resistance and reactance. In case of COPD, it is obvious that we look at the resistance and not the reactance that much. It would have been good if I would have been able to show you a graph, but unfortunately, we are running through the entire course of COPD. So I realize the time constraint. Now, R5 is one of the things that we read from the oscillometry report. And R5 is the resistance that flows through the entire lungs, whereas R20 is that what we find in the larger areas. So it is obvious that if we subtract R20 from R5, what we are left with is the smaller areas. And this is where we cannot reach when we do a normal traditional spirometry with the forced expiratory technique. And as I was listening to what Neeraj was saying, it occurred to me that we need to do these impulse oscillometries to people whom he had described as PRISM and the pre-COPD as well,
Absolutely.
Because we have
Absolutely.
all understood that COPD begins from the small airways and then maybe gradually progresses to the other airways as well. Do you want me to say anything further?
No, that's fine. No. I think that's so well described and explained, and also takes care of the audience question about the the role of impulse oscillometry, particularly in the PRISM and the pre-COPD things. So thank you so much. Now I'd like to move to Vijay. Vijay, can you just briefly explain, very briefly, explain the CAT score and how it helps us to decide the goal group?
First of all, Prashant bhai, hearty congratulations for a brilliant moderation, and then that was an excellent talk from Yuvarajan. Amazing. Within 20-25 minutes, he has covered A to Z of COPD. Nothing from our side to add, to be honest. But having said this, for the sake of discussion, CAT score is one of the wonderful scores, which is called a COPD assessment test. Many times, what happens is we may not have spirometry availability to recheck in every clinical visit of the patient. But at the same time, whether the symptoms have been progressed or not, we have to assess. So for which what the gold has come in, is introduced this CAT. And in this CAT, so various clinical parameters have been assessed with a visual analog score from 0 to 5. Almost 8 parameters are assessed. They are cough, mucus production, chest tightness, and shortness of breath on exertion, and on activities of daily life, and how confident these patients can able to leave the home, and overall energy levels and also sleep quality is assessed based on visual analog score between 0 to 5. So if the score comes less than 10, that means patients are symptomatically better. If any score more than 10, it says that they are slightly having advanced symptoms. But how it also helps us in grouping the patients into A, B, and E criteria includes. So along with this, sometimes we may need to use MMRC as well. And then MMRC is well planned, and almost we are using for decades together in practice. If any patient who have less symptoms, and then less amount of or no exacerbation in the past 1 year, we categorize into A. And those patients have more symptoms, by definition CAT more than 10, and then less amount of exacerbation, less than 1 exacerbation, or 1 exacerbation, moderate exacerbation, we categorize into B. But those patients who have more score, that is CAT more than 10 or less than 10, irrespective, but their exacerbation status needs to be considered. That means whether they have one or less moderate exacerbation, or at least 1 exacerbation that led to the hospitalization, that becomes group E. So this is what in nutshell. So essentially A, B, E. So those patients who have more exacerbation and then at least 1 hospitalization in the past 1 year, we categorize them into E. And those who have less symptoms, A, with no exacerbations or 1 exacerbation, those patients who have again more symptoms, they will be categorized into B. Prashant bhai.
No, so thanks. Very well described. As far as the CAT score is concerned, the point want to put across to the audience is, the CAT score, actually whatever we ask our patient when a COPD patient comes to us, and what we assess are the same things in the CAT score. Exactly. But the score is only systematically the whole system. The clinical assessment is put into a systematic manner, and it allows us to objectively categorize our patients. So I think that's the beauty about the CAT score. And now that we've discussed about the definition of COPD, we've discussed about the spirometry, we've discussed the iOS, we've discussed the clinical aspects and how it fits into the new groups. And now an important aspect is the radiology. So would like to ask Dr. Bindu, if you can just briefly tell us about the radiological findings on the X-ray and the CT scans in patient of COPD.
Thank you so much, Dr. Prashant and Dr. Amita, for this opportunity. Am I audible? It's
very well.
Here in Kerala, Is it okay? Okay.
Yeah. You're very well audible. Thank you.
Thank you so much. So this being an obstructive airway disease, we see a lot of hyperinflation. There is air trapping in the lung. So the radiology in an X-ray, very obviously what we see is hypertransfluent lung fields. The diaphragm is pushed down. There's a flattening of the diaphragm. The ribs are horizontal. The intercostal spaces are wide. There is tubular heart. So typical emphysema where there is hyperinflation, you can easily diagnose with an X-ray. Now, coming to the chronic bronchitis part, the chronic bronchitis where there is recurrent respiratory infection, bronchial inflammation, they may not be very specific findings, but sometimes you see prominent bronchovascular markings. Sometimes it's called a dirty lung appearance. So that is the role of X-ray. X-ray do help in ruling out the differential diagnosis, like a patient presenting with breathlessness and cough. It could be pulmonary edema or a chronic cardiac failure. So in those patients, you might see a cardiomegaly, battering appearance, bilateral costophrenic angle obliteration. So you can rule out pulmonary edema, or a case of pneumonia is there, you can rule out that, or a pulmonary embolism, which could be differential diagnosis of a COPD. You could rule, chest X-ray helps you in this part. Now, coming to the CT part, the CT will help you picking up findings of COPD, especially the emphysematous and the bullous areas, more earlier than a chest X-ray. The role of CT is important in two very important aspects. One is when you are planning for a surgery in a patient. Lung volume reduction surgeries, you need a CT to determine how effectively you can give relief, symptom relief and improvement in the lung function for these patients. So CT does play a role there. And another part is that a risk factor for COPD is also that smoking is a risk factor for lung cancer. So those patients where you suspect malignancy, you can do a screening for low dose with low dose CT, which helps you pick up early cases of lung malignancy.
Great. Thanks a lot, Dr. Bindu. So the evaluation bit is complete from a clinical, PFT, iOS, as well as the radiological bit. Now let's move to another important update in the COPD guidelines. Is we've had A, B, C, D groups. Now we have A, B, and E groups, and that was very well referred to by Vijay. He explained that. So now let's take group A, B, and E. So let's talk about group A now. Dr. Yuvarajan, can you just briefly tell us about in a very succinct way convey that A, again remind what group A is, and B, what is the treatment for that?
So already explained in my session, and also Dr. Vijay sir also explained that, sir. That is the group A patients are for those patients that have mild symptoms, very less exacerbation.
Yes.
So that means that
Perfect.
they have only 0 to 1 moderate exacerbation, not leading to hospitalization. And the symptoms also based on the CAT score, MMRC is far less only. So these group of patients, definitely they are symptomatic. They need some amount of symptomatic management with the bronchodilator. So provided single bronchodilator is effective, may be effective in this group of patients. So preferably in COPD, it's best to use long-acting bronchodilator. We can use short-acting bronchodilator as per guidelines, but my preference will be a long-acting bronchodilator because this patient will be symptomatic for a whole day. So it's always better to choose a drug with longer duration of action. So that will be my choice. And when you have a comparison between which to choose, whether we'll go for a LABA or LAMA, but there is no head-to-head, comparison studies. But there are some studies are there, but that has not shown evidence that one is superior over other. So that's why, depending upon the clinician preference, upon the availability and the cost and other things, either you can choose the LABA or LAMA for this group of patients, and you have to continue it. And other things like you should not forget that it's not the pharmacotherapy is important in COPD. I already mentioned that non-pharmacological strategies plays an important role. Prevent the risk factors, avoid smoking.
I think that's well discussed.
Physical activity, yes.
Perfect. So I think I agree with you. I think this is one of the groups, one of the areas where a single monotherapy can be given. Earlier on, we were doing tiotropium as a first option, and then now we have the option either you can use a LAMA or you can use a LABA as well. So now let's switch gears to the group B, and Neeraj, let me come to you. Can you just highlight what is the approach to managing group B, please?
Yeah, as has already been discussed, group B means those who have got MMRC score 2 or more and CAT score of 10 or more. So These patients, they do have some evidence of one or more exacerbations, but these exacerbations are usually mild to moderate and they do not need hospitalization. So these patients can be managed, very well managed, with a combination of LABA and LAMA inhalers. And these inhalers, not only they help in relieving the symptoms, they are a very good bronchodilator, and use of LAMA for a long term may prevent repeated exacerbations of COPD. As has already been discussed by Dr. Yuvarajan, there are non-pharmacological measures which are to be taken care of, including smoking, pulmonary rehabilitation, and there is a definite role of vaccination in prevention of repeated exacerbation or disease being going on progression. So LABA plus LAMA is the mainstay of the treatment of group B.
Sorry. So I think we've gone really very well from using a monotherapy to a dual therapy, and now let's shift gears to the E component. And for that, I would like to come to Dr. Angira. Can you please just tell us succinctly the approach to the management of Group E?
Okay, so initially, when we started off doing a combined assessment of COPD patients, it was A, B, C, D, like we all know this. But then why did C and D disappear and E come into the picture? So that's the most important question, I think, that needs to be addressed when you do a COPD management lecture. So E could be exacerbation, right? But E could also be eosinophils. So if you have a larger number of exacerbations going on, you've got to check the type of exacerbation that the patient is having. So if it's eosinophils, 300 counts or lesser in 2 occasions, then it's the steroids that we have to give the patient. Now, this is what the guidelines tell us, and this is the blood use. But we all know that blood use is not the only place where eosinophils hide in airway diseases. Some of them literally hide in the airways. So if we could analyze these patients and find out who these people are who have the eosinophils not only in the blood but also in the airways, I think our management would be much, much better, even better than these guidelines. So if it's eosinophils, add an extra thing, which is an inhaled corticosteroid. So inhaled corticosteroids have a lot of side effects, we all know that, but to monitor a patient who's having an eosinophilic disease, you've got to do a blood use as well as a sputum use count. So another aspect is that guidelines always tell us that you use a combination therapy, which is much better than a single drug or 2 drugs. And my contention to that would be, if you want to adjust the dose of steroid, we won't be able to do that if we are using a combination inhaler which has all 3 components, a LABA, a LAMA, and a. So that's something to think about. It may not always be a good thing to do, but it may be in certain cases. So I'll stop there because the eosinophil story can go on forever and ever and ever. So thank you.
Yeah, absolutely. I think this is such an important point. I think the E for the exacerbation, E for the eosinophils, and the use of triple drug. So we move from monotherapy to dual therapy, and now when it comes to E, we talk about triple inhalation. And what you said is right. I think there are the single triple drug combinations which are available, which surely have their own advantages. And I think a point may come where you may want to use a slightly lower dose of the inhaled corticosteroid. Yes. So in that case, that it is also possible. And I think being in India, in our country, we've got such a huge basket and combinations of various molecules that we are able to actually choose the medications appropriately. The advantage, when we talk about the group E and a triple drug therapy is now, clearly we have a once a day therapy, which is available already. We've got combinations of a triple drug therapy, which can be given morning and evening in an NDI form. We've got a combination therapy, can be morning and evening in a DPI form. And I think that's sometimes a big advantage as far as compliance is concerned. And if the administration of the ICS is what you would like to give, there are select patients where I would like to give a lower dose of ICS. I'm expanding a bit on this because I think this is a very important aspect, where I may want to give a lower dose of the ICS. And then we have this basket again. I can choose my dual bronchodilator separately, and I can choose to administer the inhaled corticosteroid also separately. So I think we are in a good scenario where we are not forced to administer a fixed dose or a high dose of, or in some individuals which may be a higher dose. Where would I like to have a lower dose is particularly if infections is an issue. I mean, that's my take on it. But of course, like it was very well said, we can keep on discussing. All this can be a chapter by itself.
So when
Do you have
we
any
want a
comment before
lower
I move
dose
to
of,
the next?
I just have one point to make. So if this is a sort of a
Yes.
humorous talk, so just one line. If you want to give a patient a lower dose of steroid when he or she is on free drug therapy, then how do you do that? Just break it.
Yes. So I mean, I think that's a good point. But I think fortunately, we have a
We don't
huge
have-
basket from where we can choose. So now let's move. I think the other important, we've been talking about E for exacerbation. We are talking about as far as E is concerned for eosinophils. Now I would like to come to Dr. Bindu. If you could just again talk about then acute exacerbation. I mean, we've discussed, how we should approach inhalation therapy in individuals who are having exacerbations. But now, how do we approach an acute exacerbation? Succinctly, please. Thank you.
Yes, the definition was keeping on changing, and currently it has become an event in the natural course of the disease which is characterized by change in the patient's symptoms. That is, there is increase in dyspnea, cough with or without sputum, which is different from the normal day-to-day variation, which warrants a change in the medication in a patient with COPD. So patient comes with increased breathlessness, cough with or without sputum. We need to clinically assess and confirm whether it is an acute exacerbation of COPD. And once you have confirmed it, that is, you have ruled out cardiac failure, pulmonary embolism, pneumonia, pneumothorax, all those things, and you have confirmed your diagnosis that it is an acute exacerbation of COPD, we need to assess the severity of COPD. The severity could be mild, moderate, or severe based on the respiratory rate, heart rate, the saturation, and the clinical use of accessory muscles. And once you have assessed the severity also, and you have done the clinical, we need to find out the etiology of acute exacerbation. It could be a viral exacerbation. The sputum could be sent for bacteriological culture. And once that is also done, we can do the ABG, a chest X-ray. And when all the assessment is done, we can go in for the management. That is, immediately you could start oxygen. And we need to put in short-acting bronchodilators. If the patient is already on a short-acting bronchodilator, you can increase the dose. And preferably, you can use a beta agonist with or without an anticholinergic, which could also be a short-acting one, which could be an ipratropium. And in addition to the bronchodilator, you need to give systemic steroids. It has been shown that systemic steroids do reduce the hospital stay, improves the oxygenation, improves the FEV1 in a patient who is presenting with an acute exacerbation of COPD. And antibiotics, the role of antibiotics is also very relevant if the presence of bacterial infection has been proven. If your patient does not improve with your bronchodilator, systemic steroids, and oxygenation, then the next step is going on for a non-invasive positive pressure ventilation. There's a definite role for positive pressure ventilation and intensive care.
Great. Thanks a lot. So I think that's a good overview. Of course, Yuvarajan had explained that, but again, in context, in a split manner, I think we are going step by step. So very well explained about the approach to acute exacerbation. One thing I would like to add here is that, we speak about systemic steroids, and there's been a very important trial that was published in JAMA, that is the REDUCE trial. and the reduced trial is also a part of GOLD guidelines. They do refer to that, and just want to take a minute to highlight that. In reduced trial, what was done is, there were two groups. It's a randomized trial, two groups of patients. One group where the physician would give steroids as per the clinical judgment, which could be up to 14 days. And in the reduced trial, if you were randomized to the test intervention arm, you would receive only 40 milligram of prednisone for 5 days and stop. Okay, and the trial has shown that 40 milligram in an acute exacerbation, giving 40 milligram once a day for 5 days is enough and has a similar outcome than you would give a prolonged and a higher dose of prednisone. So I think as far as systemic steroids are concerned, I find this a very important paper, and I have adopted this well in a majority of my patients in clinical practice. Now let's move gears on. Let's move to, say for example, we've spoken about triple drug therapy, patients on triple drug therapy. What if these individuals continue to be symptomatic on triple drug therapy, and if they develop exacerbations? Vijay, can you just help us with this group of patients?
Sir, okay, it is not really uncommon to have these group of patients in our clinical practice day-to-day life. They do exacerbate despite on triple therapy. It is our meticulous history taking, whether these are all, even the GOLD clearly mentions, whether these are all, if they have excess mucus producers, and if they have FEV1 is less than 50, they would be the right candidates probably, if we may add roflumilast, which is one of the, as Yuvarajan was mentioning, okay, though it was available for the past close to around 7-8 years in practice. So nowadays we are not using that often, but this drug is one thing which is a PDE4 highly selective inhibitor. By increasing CAMP levels, would cause reasonable amount of bronchodilation. This can be particularly used in chronic bronchitis patients with FEV1 less than 50. And other important drug, which I'm sure we all must using is something like the long-term usage of macrolide. So it plays a very, very crucial role in management of COPD, particularly if they are having a former history of smokers. And more importantly, in India, it is with the probably recent trend of doing a CAT scan. So if they have a significant bronchiectasis behind the COPD component, then probably these are the patients, they get benefited with long-term usage of azithromycin, so that we can decrease the number of exacerbations, sir.
Yeah, thanks, Vijay. I think that was very well explained, and I think roflumilast, azithromycin, these are forming important medications. Also, some people can also think about N-acetylcysteine, which is which has been shown to be a weak supportive therapy, but has known to help a few patients, a select group of patients, I would say. It helps everybody, 600 milligram twice. So that's also one of the additional therapies. Now, we come back to Dr. Yuvarajan. He's in his talk, he very well mentioned about the taking care of the comorbidities as far as the COPD is concerned. So not wanting to make it a repetition, but can you just highlight the important points as far as the COPD and comorbidity management is concerned, or the approach rather? Just give us the approach, please. Thank you.
So COPD is rather a systemic disease. You should not think it is involving only lung. This is an age-old concept. As I already explained in my presentation also, we need to give importance to cardiovascular system. There are a lot of cardiovascular diseases associated with COPD because they share a common risk factors, increased risk of hypertension. In the hypertension, specifically, these patients are more prone for diastolic dysfunction, sir. So this diastolic dysfunction, if they are not managing hypertension properly, this patient can present as heart failure with a preserved ejection fraction, which resembles like a COPD exacerbation, because we see the patients like that only. Then when you see their control of BP may not be adequate, and then they have a diastolic dysfunction. Then one second they'll roam around cardiologist and pulmonologist. This is one point, sir. Another thing, like they have high risk of ischemic heart disease that you should not miss, because they have a common symptoms that are shared. And that's why this comorbidity should not be missed. And then the risk of, cerebral vascular disease and accidents, all these things are there. Most important thing is they are psychologically upset. They have high incidence of anxiety and depression. So they have a fear of, going to the closed rooms, they're going to the function, all these things. All these things has to be taken care of. And because of restriction activities, osteoporosis is very high. And then muscle wasting is also there. So all these things has to be taken care of. And important point I've shared is that these patients are having high incidence of interstitial lung abnormalities. Specifically, in COPD gene study, they have mentioned that almost 1/3 of patients have some form of interstitial abnormalities when you do a CT screening. And both diseases are separate. And this will increase the symptoms, increase the worsening of this group of patients. So that we have to check. Lung cancer. Lung cancer, we should not miss. All the patients with COPD, definitely we need to see that the lung cancer, all this. A lot of number of comorbidities like OSAs are there, because those patients who are obese, having disproportionate, pulmonary pressures, even though if we manage properly, you have to think of OAs and all these things. So all these comorbidities has to be taken care of when you are managing COPD.
So I think that is so very well, you started off very well saying that COPD is a systemic disease, and that's what we have to see. So when, it's very important to convey to the patient also when they come to us in the OPD, otherwise they say, "Saab, hum to aaye aapke paas breathlessness ke liye, ye sab baki ka kya chal raha hai?" So it's important to convey. May not be the first visit, they're going to follow up with you. So at every visit, in the first few visits, I would say, I think without actually scaring them, but at the same time, important to educate them that yes, it's a systemic disease. We need to take care of other things other than just the inhalation therapy. And of course, again, this is a topic by itself, and I think you've summarized it very well. Now, there's an important aspect, where whenever we were doing exams and exam question, the point comes to alpha-1 antitrypsin, and you also refer to alpha-1 antitrypsin as well as the etiotypes of the COPD is concerned. Neeraj, can you just, briefly tell us the approach to and the differentiation between the usual COPD and alpha-1 antitrypsin COPD and how one would approach that?
Yes. As has already been told by Dr. Yuvarajan, that alpha-1 antitrypsin deficiency, although it is common in Western countries, it is very, very uncommon, commonly seen in our country. Almost, if we go through the literature, almost 5% of the patients with COPD, they do have alpha-1 antitrypsin deficiency. But out of these 5% patients, only 4 to 5% patients are being diagnosed with alpha-1 antitrypsin deficiency. So the number is very small, but there are very typical clinical features which can differentiate COPD because of alpha-1 antitrypsin deficiency from those COPD patients who develop COPD secondary to smoke or occupational exposures. These patients, they are usually of young age, and they are non-smokers. They do have a diffuse pan-acinar emphysema on their chest radiographs. Of course, these patients, they should be managed as patient of other COPD. There should be optimal bronchodilator therapy. But here comes a role of pulmonary rehabilitation. These patients should strictly undergo a regular pulmonary rehabilitation so that their sense of breathlessness is reduced and they lead to a normal life. Whenever it comes to the surgical management of emphysema, we can see that the surgical management, they are less effective in patients with alpha-1 antitrypsin deficiency as compared to those with large bullous disease. But of course, there are reports that alpha-1 antitrypsin replacement is useful in these patients, which can be either by the intravenous route or by the inhalational route or by the nasal replacement therapy. Apart from these,
so I think that
these patients, they develop severe emphysema and they land up into a respiratory failure. Then, of course, lung transplantation is the answer.
Yeah, I think that's very well said. So I remember during my earlier time when I was in lung transplantation, we had severe patients with alpha-1 antitrypsin whom we had offered transplantation, and I think that's going to be discussed further down during the towards the further part of the panel discussion. So I think this is very well covered. I think we covered a lot of aspects of COPD. Now we move to a very important aspect of of COPD that we see in clinical practice, or rather, is often discussed also, is the asthma COPD overlap. And for this, I would like to ask Dr. Angira, what would you, what is echo, and what is the approach, briefly, towards managing echo?
Now, the new guidelines, they have mentioned very clearly that they do not believe in the concept of echo. So, but in clinical practice, we are all getting these patients where there is a partial reversibility, maybe, and eosinophils in the blood sputum. So these patients should be treated in lines of asthma. That's what clinical practice says. But then again, there is a very good thing, which is an approach to these patients, which is outside of the guideline therapy. It may be helpful to the students to know this, but please do not express these things in your exam.
Yeah.
It should not be, because it's still ongoing research. So if we imagine airway diseases, that is all of them, asthma, COPD, bronchitis, cough, for the matter, of comprising of three important components, that's an airflow obstruction, bronchial hyperresponsiveness, and eosinophilia, then you don't need to name a person's disease about having COPD or asthma or an overlap, so it's not required. Just identify the particular factor that is causing the disease, that is uncontrolled in a particular patient. And then from there, we can go on to treat that component. So it's just teasing out whichever component is uncorrected at that particular moment of time. For example, if we have a airflow obstruction going on in a patient, the patient is wheezing, the patient has a silent chest. So clinically, we understand that the patient is having an exacerbation of the obstructive component of the disease. So in such a case, we give nebulization with bronchodilators because we need very high doses of bronchodilation. Secondly, if we find that the patient has an increased number of eosinophils in the blood, like we discussed earlier, then the steroids would be the correct thing to use. Neutrophilia, yes, of course, we have to give the antibiotics. And the third component is that of bronchial hyperresponsiveness, which may not be very important in exacerbating patients, but it is very important if the patient has a normal spirometry with symptoms going. Because a normal spirometry does not necessarily rule out as, or for that matter, overlap. So these three components are of paramount importance, because these, if we use these three component concept, we can adjust the dose of the drugs in our patients as well, and we can do that very minutely. Eosinophils in the blood need to be less than 300, so increase your steroids, either increase or you may also need to decrease them. And the airway eosinophilia is another important thing which can help us adjust the drug doses. So if you have an ICS that the patient is getting, for example, say a budesonide of 200 micrograms, you find the sputum eos to be more than 4%, that's abnormal. You could increase your budesonide dose to 200. Again, if you find that your blood eos have gone down to 100, the patient may not need the steroid inhaler any longer. So 3 components, tease out which one is not important, which one is important and uncontrolled in that very particular patient, treat that component. This is something which we should all be doing now.
Amazing, amazing. So well, Dr. Angira, thank you so much. You've really explained it such a simply and a clear manner that ECOS is now out, but how do we tackle this this component that we see in clinical practice, and all the 3 points so well said. And I think it's a very important point also about the ICS, about increasing the ICS, decreasing the ICS, and how we can use different measures. And of course, one has to go into the depth. That extra effort needs to be taken so that we can titrate the medications well. Thank you so much, Dr. Angira. Now, we would like to move to the other aspect of COPD management, which was again discussed. Of course, all aspects were discussed by Yuvarajan, but now I would like Dr. Bindu to just highlight the usual non-pharmacological treatment of COPD. If you could just briefly highlight the approach towards that.
The goals of treatment of COPD, one is to reduce the symptoms, that is grossly your pharmacological management. And the second part is to reduce the risk. So reducing the risk is primarily you're trying to prevent the progression of disease. And the most important part is smoking cessation. It's very important for the treating physician to ask, assess, advise, assist, and arrange follow-up, the 5 A's and smoking cessation. It does play a very important role in preventing the progression of the disease. The next important part is pulmonary rehabilitation. In non-pharmacological management, pulmonary rehabilitation is indicated in all those COPD patients who have relevant symptoms and repeated exacerbations. And physical activity has been given a very important point in the GOLD 2024 guidelines. They've given evidence A for physical activity in reducing the morbidity and mortality. And so muscle strengthening exercises, breathing exercises, nutrition does play a very important role. And the third is prevention of disease exacerbations as vaccinations. GOLD has come up with 6 vaccinations, influenza every year, pneumococcal vaccine, the PCV 15, followed up with a pneumococcal PPSV 23, or if you have a PCV 20, that will do. And the COVID-19 SARS-CoV vaccine, the pertussis vaccine, if you haven't taken it during the adolescent period, the shingles vaccine, and I missed out one more vaccine as there.
RSV.
The RSV is the RSV.
Yeah, respiratory syncytial virus. The
Yes,
vaccines.
yeah,
It's
yeah,
vaccines
the
for
RSV
that,
one.
you know.
Yes. No, so I think that's very good. I think it's really a very good summary of the non-pharmacological approach, and I think this is also an important part that would need to be conveyed to the patient, because again, patient will often come with that thing in mind that I've got every disease, I need to take the inhaler and out. No, I think again, as Yuvarajan said, it's a systemic disease, and we need pharmacological as well as non-pharmacological treatment, including the nutritional support. So I think it's a fantastic learning and summarizing for yes, please.
Shingles vaccine has been given in COPD about 50 years. The age
Yes, it is. Absolutely, yes, about 50 years of age. That's correct, and that's what the approval is for. We know in the West that for shingles also there is approval above the age of 18 also, but in India, yes, it is above the age of 50. Now, this is such a fantastic session which is going on. I'm learning a lot, but I have to go, and I'm now would like to hand over the moderation responsibility to my dear friend Neeraj. If you can please take over from here. And once again, I really want to thank Amita, ICS, Lupin for the organizing all this, and want to thank the speakers and the panelists for this learning that I've got. Thank you very much.
Thank you, Dr. Prashant.
Yes.
We would love if you could continue till end.
Yeah. Sorry. No. If I don't go, my daughter will not have dinner. So I need to go. Yeah, she's just come from a dance class. I need to get the dinner for her. Yeah. Bye.
Okay. Thank you very much.
Thank you, Dr.
Explain moderation till now. So next question, Dr. Vijay.
Yeah.
What is the same therapy and criteria of LTOT in COPD? So a lot of our patients, they need oxygen while they are hospitalized and they are being discharged on oxygen. What are the criteria for LTOT?
See, I'm sure as per the WhatsApp group, there are hundreds of postgraduates, hundreds of pulmonologists across India. They are listening to us. Those who are beginners, okay, please understand oxygen is a prescription. As you prescribe an inhaler, as you prescribe an antibiotic, oxygen is also a prescription. So that's why. So please understand the first and important rule before you prescribe oxygen to someone is, so whether they have stopped smoking or not. So if they haven't stopped smoking, please counsel them. The oxygen is an inflammable gas, and then don't combine both oxygen and smoking together. So that is the first and most important thing that you should check, you should ask, and then start prescribing the oxygen. And coming to the indications, if you see, first of all, we'll see whether it is going to affect the long-term oxygen therapy in patients who are stable COPDs and those patients who are having only exercise-induced desaturations. No, my dear friends, it is not going to improve any mortality benefit or any morbidity benefit in this group of patients. But it is definitely going to, as per the NOT trial, nocturnal oxygen therapy trial, it is clearly mentioned those patients, it was compared those patients who were given 19 hours of oxygen and then versus 13 hours of oxygen. It showed there is a 50% reduction in mortality, and which is very, very clinical significant. And the recommendations then after is those patients who have a resting PaO2 level less than 55, or those patients who have resting PaO2 less than 60 in combination with the carpal nail, or those patients who have a secondary polycythemia as defined by the hematocrit values elevated. In males, it is more than 51%. In females, it is more than 48%. And or the simultaneous, the hemoglobin values in males more than 18.5 and in females more than 16.5 gram per deciliter. So it is very, very important. The supplementation of oxygen at least 19 hours in this group of patients is going to increase the PaO2 levels and it decrease the mortality. Over to Neeraj bhai.
Excellent, excellent. So the crux is that there is nothing like nocturnal oxygen therapy. There is nothing like intermittent oxygen therapy. When you have to give oxygen to a patient with COPD who really requires it, it is to be given almost round the clock, almost 18 to 19 hours per day. It's not only that some of these patients, they get comfortable, they get a lesser sense of dyspnea because of oxygen, they should be given. No, there should be strict criteria. Always go for a blood gas analysis and then decide who are the actual candidate for long-term oxygen therapy. So my next question is to Dr. Yuvarajan. What are the indications for BiPAP and AVAPs in COPD? There is one question also in the chat box.
Yes, sir.
Yeah.
Yes, sir. So let me discuss some three situations. These are the common three situations we use NIV, usually preferably a BiPAP. So first one is acute respiratory failure. Those patients who present with exacerbation in the form of respiratory failure, which is non-life threatening, we have to choose NIV if the patient presents at least one of the following. Like if they have a disturbance in the ABG parameters showing signs of acidosis, if the pH is less than 7.35, but it should be more than 7.25. Because, less than 7.2 is a clear-cut indication that the patient have a moribund status, is conscious as everything will be disturbed, and that patient, we need to put the patient on invasive ventilation. For that group of patient also, we can try NIV trial, but with strict precautions. So, pH less than 7.35, any patient with respiratory acidosis with a PCO2 more than 45, are the patients who present with the exacerbation with dyspnea, with increased use of axillary muscles for respiration, and persistent hypoxemia even after giving oxygen therapy. So these group of patients, after an acute exacerbation, who present the respiratory failure, definitely NIV plays a major role because it improves the work of breathing, improves the ventilation perfusion match, and then it reduces the hyperinflation, and it also prevents the patient to go for a invasive mechanical ventilation. So that is one thing. And second set of patients, like those patients after discharge, the COPD patient after exacerbation, after discharge, how long we have to use BiPAP and which group of patients we have to do BiPAP. So these patients actually, this is critical to decide because the patients actually who present with hypercarbia at the time of presentation and at the time of discharge, you need to have a clinical assessment. What ATS and Canadian recommendation, what they are telling is that you need to you can give BiPAP for these patients, but you need to reassess the patient after 2 to 4 weeks, whether they need a long-term BiPAP or not. That means that a home-based BiPAP, whether you need or not. Or we need to switch off the BiPAP and continue with your regular maintenance therapy with other strategies as we were discussed all the time, like till now. So this group of patients, like after 2 to 4 weeks, if they still we can do ABG. If the ABG shows still PCO2 well above that 53, then 50 or 53. So this group of patients, we can give a long-term BiPAP. So next group of patients is giving a home-based long-term BiPAP. whether we can give for all the COPD patients. No, those patients who have a chronic, hypoxemia with hypercarbic respiratory failure, and those have a persistent PCO2 elevation, their ABG, symptomatic. This group of patients, we can give a long-term BiPAP. So when you are giving long-term BiPAP, we can't expect a magic to happen like, it won't reduce the mortality per se, but it improves the dyspnea and other things in this group of patients. And next part is that like AVAPS mode. So which group of patients we can use AVAPS mode? So AVAPS mode is the thing is that average volume assured pressure support mode, which is a specialized mode that we use in BiPAP. See, this is the thing is that like here our inspiratory positive air pressure is auto titrated, and then which delivers tidal volume breath to breath, and then which also changes with each breath to breath to maintain adequate alveolar ventilation, so that it puts a check exactly for the CO2 that is responsible for all the things like PCO2 retention and all. So, but what the guidelines is recommended, we don't have a strong supportive evidence for AVAPS based on the studies. What they are telling that at present we can use a conventional mode, but those patients who got a long-term requirement for this BiPAP, we can prefer AVAPS mode. And one important settings for BiPAP is that when you are giving home-based BiPAP, we use high-intensity mode. For all the PGs, we use high-intensity mode. That means that high intensity is that we give higher pressures with higher respiratory rate. Initially, they told, but now we should not give higher respiratory rate. We need to give higher pressures only. So inspiratory pressure will be set way above 18. Then only we can compensate the airway spasm so that we can push the air into the lung, and we can just take the carbon dioxide out of the lung. That is very, very important because we need to check the PCO2. That is a target for all the guidelines. So PCO2 has to put a check on. So because higher PCO2 causes, all the, disturbance in the day-to-day activities and the exacerbation and all cause mortality. So we need to check, put on. So we need to choose a high intensity mode in a BiPAP.
So very well explained, very well explained. So it is very important that those patients who are suffering from chronic respiratory failure, they have persistent hypercapnia, especially above 53. These patients should be treated with BiPAP. But of course, optimal bronchodilator therapy, oxygen therapy, they all should be taken care of before they are put on non-invasive ventilation. So now we come on to the pulmonary complications of COPD. We know that there are pulmonary complications as well as extra pulmonary complications of COPD. For example, the pulmonary complications, we do come across these cases with repeated incidences of pneumonia, pneumothorax, pulmonary embolism, right heart failure, then of course chronic respiratory failure. So my next question is to Dr. Angira. So what are the non-pulmonary complications of COPD and how do you manage them?
So like we have already discussed that this COPD is a systemic disorder, and hence there are several organ systems which might be affected, which during a person who has COPD assessment is being done. The first thing that we know is that there is a lot of hypoxia that goes on in these patients. And in order to combat that hypoxia, the kidneys sometimes take over and they secrete more of EPO, that's erythropoietin. And once they do that, there is synthesis of more amount of RBCs and hemoglobin, and we get a secondary polycythemia. Now, how do we treat this secondary polycythemia of COPD? We have to do a venesection. That is what is indicated, which is not a nice thing to do, but it saves the patient's life sometimes from having an episode of CVA. Next, we have a lot of hypermetabolism that goes on in these patients, especially those with severe emphysema. Now, if there is hypermetabolism, then there is a lot of energy that is being spent. The first one being for the muscles. So if there is muscle energy that is being spent and not replenished, we get a muscle atrophy, and this leads to deconditioning and further deconditioning in a vicious cycle. So the nutrition factor needs to be taken care of in these patients. And apart from nutrition, we need a pulmonary rehab in these patients, which would include not only the education and smoking cessation, but also exercise training. From the 6-minute walk test, we can do a prescription training for these patients. And that is very, very important. And we must not forget this while we are writing a prescription in COPD patients. And we've already touched upon this. Patients sometimes lose hope. They feel helpless. They feel depressed. And it is also part of our clinical acumen to pick up these patients and treat their depression. Because unless we treat their depression, the patients are not going to get well. They might continue to dip down in their social life and the feeling of hopelessness and might not recover at all. So I think these are some of the extrapulmonary complications of COPD that comes into my mind immediately.
Yes. It is very important to recognize these extrapulmonary complications of COPD in our patients. Just whenever you are on ground, just have a look on the hematocrit, because these patients, they may have polycythemia, and it should be properly taken care of. Again, very well said, 6-minute walk test has a very important role in management of COPD, and it should be done whenever it is indicated. Of course, general physical examination and facies of the patient may be very important. Some of these patients, they may be anxious or they may look depressed when they come to you in your clinic or in the OPD. So counseling is again very important. So recognition of extrapulmonary complications is equally important, and managing them will definitely help in reducing the symptoms of dyspnea in these patients. Coming to the surgical management of COPD, Dr. Bindu, can you enumerate certain surgical interventions which can be done in patients with COPD?
Very importantly, lung volume reduction surgeries. COPD, what happens is there are some areas of dead space developing in the lung, and in these places there are VQ mismatch. So if these bullous areas or the bulla are removed with a lung volume reduction surgery, it has been shown that it improves the survival of the patient, and the symptom of breathlessness is very much reduced if effectively done. Similarly, if in a patient with emphysema who has a very large bulla, the bullectomy will help the patient in improving the symptoms, improving the FEV1 and the morbidity of the patient. And in patients where, in spite of your optimum management, pulmonary rehabilitation, and still the patient is not improving, lung transplantation is the final surgical management which we can offer to the patient. And the newer developments are bronchoscopically installation of valves and coils, which will be discussed in the subsequent discussions. So those are the basic things: lung volume reduction surgery, bullectomy, and finally lung transplantation if indicated.
So there are many surgical procedures, including bronchoscopic procedures as well as VATS, as well as other kind of open surgeries of the lungs. So I think bronchoscopic management of COPD seems to be very fascinating. Dr. Vijay?
Yes, sir. So I totally agree with you. It is if we see past 1 to 2 decades, it is the COPD patients' life is going to be really revolutionized with these kind of procedures. Unfortunately, we have very, very limited interventions available in India. But when we look at the West, it is quite promising, and it is giving very, very good results to my best of the knowledge. But do you think these interventions is going to help in patients with low symptom scores like low CAT score, low MMRC? Not at all. So these interventions are reserved for those patients who have very severe degree of emphysema, which handicaps the patients to perform their even activities of daily life. And again, the recent literature which is coming, which states very clearly that we have to select these interventions in such a group of patients where their functionality is not really low or really high. So there's a thin line there, what we can call it as a Lakshmana Rekha. So it is very, very important. But what it is going to do is, as others, my colleagues clearly mentioned, it is going to decrease the air trapping and optimize the FRC and then residual volume, resulting the placement of the diaphragm at a mechanically advantaged position so that it is going to decrease the symptoms, increase the lung function, particularly FEV1, and also increase the effort tolerance. Various bronchoscopic techniques in the interest of time, I'm going to tell very briefly, sir. So various techniques like endobronchial valve, lung coils, thermal vapor ablations, sealants, airway bypass stents, these are all available. But in India, what is available so far is bronchoscopic thermal vapor ablation. What it is going to do is, when we deliver, so when we look at the CTs, the beauty of vapor ablation is, it is going to helpful even in the patients with fissures which are partly formed, and also those who have got collateral ventilation. So that's why vapor ablation can be, which is available at least to my best of knowledge, 5-6 centers in India, and then almost close to 80 patients were being offered in the past 1 year in India. So it is going to, I think, in Indian patients, how far it is effective, only time has to tell. So far, the complication rate of vapor ablation is reasonably less to my best of knowledge, sir. Over to you, sir.
So yes, there are very less centers in our country where the bronchoscopic interventions to manage COPD is being done. But of course, these procedures, they seem to be very fascinating, and I'm sure that in near future, more number of centers will be available. Yes, Dr. Angira?
I thought I would just contribute to what Vijay just now said.
Yes, yes.
Selection of the patients who would benefit from a bronchial thermoplasty or vapor ablation is very important. And the way we do it is by first eliminating the inflammatory component of these patients. Once that is done, what remains is the twitchiness or the bronchial hyperresponsiveness of the bronchus. So in these patients where the only component that is uncared of or untreated is the twitchiness or the bronchial hyperresponsive thing, muscle related. So if you do a bronchial thermoplasty in such very carefully selected patients, the success rate would be much higher than what we have. The patients, from what I've seen, is that patients need to come back again and again and again to get a sitting of thermoplasty done. If we would have done the phenotyping correctly, then number of times must have decreased. That's my take on it.
Yes.
Neeraj bhai, just to add, since the thermoplasty is no longer being offered and across the globe, there is no point in discussing even Dr. Angira regarding thermoplasty, and it is mainly being offered for chronic persistent asthmatic patients with severe asthma component.
Yes, yes. Now thermoplasty is almost obsolete and is not being done by those who have got these instruments available in their institutions. So just to add in the bronchoscopic management, can anybody comment on the collateral ventilation? How do you assess and how they can help?
The collateral ventilation generally is assessed by various software that is available in the market. So once we have the facility of these vapor ablation techniques, what they do is these collateral, they do a very good CAT scans. They assess the fissural integrity. And fortunately, in India, almost 90% of patients will not have any complete fissures. So it is these softwares which assess mainly the companies which they assess from the central locations, particularly from US. So where they assess the fissural integrity, which segment has to be ablated first, which segment has to be ablated second, and then the last priority segment, which one has to be ablated. They give the software protocol so that we can execute here, sir.
Thank you. Now the last question, Dr. Yuvarajan. What about lung transplantation in COPD?
Yes, sir. So those patients who got very severe COPD, who have a progressive disease, which are not amenable for management with all your standard therapies. Definitely, we have to think of lung transplantation. Especially, we need to consider the Body's index. So if the patient having Body's index of well above 5, especially within 7 to 10, or those patients who have frequent exacerbations, or those patients who have a homogeneous disease. Because actually we can offer a bronchoscopic treatment for those patients with heterogeneous disease. So those patients who have homogeneous disease, frequent exacerbation, having very low FEV1, that is less than 20%, with all your moderate to severe pulmonary hypertension, with all this bodies index, poor bodies index, higher bodies index, we can refer them for lung transplantation.
So I think this is all with the questions in our panel discussion. There are certain questions in our chat box. I think most of the questions they have been taken care of. There is one question: COPD bronchiectasis overlap. Can anybody comment on that?
Yes. Yes, sir.
Yeah.
Sir, yes, sir. Of late, we are seeing COPD bronchiectasis in certain patients, sir, but we don't have a proper, clinical studies and data how to manage this group of patients. Because one is having, the patient will present with a copious amount of sputum and expectoration. So they have a collaterals, they have a bronchial circulation taken over. So in this side, there is a, damaged, distal airways with emphysema and all. So with both the diseases are there, there is a profound ventilation perfusion mismatch, and they have a high incidence of hypoxemia and severe pulmonary hypertension. So what is my experience that those patients who have a COPD in bronchiectasis, having a full-blown disease, so these patients comes to hospital frequently with exacerbation, and they have a profound hypoxemia. At the same time, they have a disproportionate pulmonary hypertension. So those patients who have a disproportionate, PHT, so always you have to consider other morbidities, and bronchiectasis is one among them.
And just to add to what Dr. Yu has said, so it is very, very important to decrease the exacerbations in these group of patients, more importantly than COPD. And then eradication of Pseudomonas in these patients has become a very, very huge challenge, huge task in clinical practice. So that's why we should focus on keeping the Pseudomonas away from these airways from COPD plus bronchiectatic patients.
So another question from the chat box: what is place of?
Would like to add to what has already been said.
Yeah.
Okay, so when we did clinics long time back, so we were taught in our clinical classes that if there is a clubbing in a patient of COPD, then the patient has bronchiectasis or lung cancer. So just a quick reminder for this clinical tip.
Brilliant, ma'am. Brilliant.
So place of Edostein, experience, evidence, does anybody have? At least I have personal experience with Edostein. The patients are quite happy. It's a good mucolytic, and these patients, they do well when it is being added to a proper bronchodilator therapy. Anybody who can?
Yes, sir. It's less pungent than acetylcysteine. There is no side effect of intolerance, particularly gastric intolerance, with Edostein when compared to acetylcysteine.
So I think, can we finish here? It's already 10:24.
Carbonic anhydrase inhibitors. COPD. So there's a question. Well, sir, when and how to use carbonic anhydrase inhibitors in COPD patients, they have asked.
Okay.
So that means that they are asking acetazolamide, sir. Sir, actually, I think
probably
the age-old study, those patients who present the type 2 respiratory failure, we don't have any other drug to offer to promote them to wash out their CO2. So there is an age-old study, they have used this carbonic anhydrase inhibitors, acetazolamide, along with medroxyprogesterone. It has to be given in combination, and which helps us to improve their PCO2, to reduce their PCO2. But the problem with carbonic inhibitor is that it will cause bicarbonaturia and it will promote acidosis. It will promote more acidosis. We need to actually check exactly very closely the pH. If you are giving Dimox, that is acetazolamide, we need to check very closely. It is risky only. So all the newer studies, they have not included new recommendations. They are not advising carbonic inhibitors, especially for COPD.
So I thank Indian Chest Society to invite all of us for this excellent interactive webinar. My special thanks to Dr. Amita Nene, Prashant Chhajed, Dr. Yuvraj, Dr. Vijay, Dr. Bindu, and Dr. Angira. Thank you very much.
Thank you, sir.
Most of the questions I
Yes, sir.
think they have already been taken care of in the chat box. Dr. Yuvarajan was busy in replying all these questions. Thank you, Dr. Yuvarajan, to make the task easy. Thank you very much.
Thank you,
Thank
sir.
you.
Thank you so much. It was a brilliant moderation by both you and Prashant Bhai.
Dr. Chhajed.
And
Time
Yuvarajan,
was
that was a mind-blowing talk.
Thank you, sir.
You did so quick.
Thank you.
Absolutely,
Credit goes to
absolutely. I
everybody.
enjoyed.
Credit goes to everybody in this
Thank
panel.
you.
And Angira ma'am, very good to meeting you. Okay. Bindu ma'am, I have met before. Hi ma'am.
So it was nice participating in the webinar. And Yuvraj, you've got to slow down. The goal guidelines in 15 minutes.
Thank you.
But it was really, really nice. It's very, very nice.
Thank you.
Thank you, sir. Thank you so much. Thank you all. Good night. Bye-bye.
Good night. Bye.
Yeah, thank you so much, everyone. So from here, I'm ending this meeting. Thank you.